Today's lecture will be about the wrist ultrasound, also the technique of the scan and the most common pathologies. This is an MRI demonstrating the normal anatomy of the wrist tendons. Regarding the flexor group, there is the flexor digitorum profundus and the flexor digitorum superficialis tendons. Together with the flexor pollicis longus and the median nerve, they pass into the carpal tunnel. Outside the carpal tunnel, there is a tendon at the ulnar aspect, which is the flexor carpi ulnaris, another one at the radial aspect, which is the flexor carpi radialis. Another superficial tendon is noted just under the skin and the subcutaneous tissue, which is the palmaris longus. Regarding the extensor compartments, it is divided into 6 compartments. Our landmark is the Lister's tubercle. Medial to it is the third compartment, which contains the extensor pollicis longus. Then laterally is the second compartment, which contains the extensor carpi radialis brevis and the extensor carpi radialis longus. Then the first compartment, which contains the abductor pollicis longus and the extensor pollicis brevis. Then moving to the medial aspect after the third compartment is the fourth compartment, which contains the extensor digitorum, and the fifth compartment, which contains the extensor digiti minimi, which is located above the radio-ulnar joint, and the sixth compartment contains the extensor carpi ulnaris. Here is another demonstration for our landmark, which is the Lister's tubercle. So this is the third compartment, extensor pollicis longus. The second compartment, extensor carpi radialis longus and brevis. Then the first compartment containing the abductor pollicis longus and the extensor pollicis brevis. Then medial to the third compartment is the fourth compartment, which contains the extensor digitorum, and the fifth containing the extensor digiti minimi, and the sixth containing the extensor carpi ulnaris. This is an ultrasound of the carpal tunnel. The thin line here is the flexor retinaculum. Beneath it is the median nerve, then the flexor digitorum superficialis and the flexor digitorum profundus. Another tendon in the carpal tunnel, which is the flexor pollicis longus, seen at the radial side. Outside the carpal tunnel, there are two tendons, one at the radial aspect, which is the flexor carpi radialis, above the scaphoid bone, and at the ulnar side is the flexor carpi ulnaris over the pisiform. Then the ulnar artery and the ulnar nerve. The ulnar nerve passes at the distal end of the radius in a narrow area, which is called the Guyon's canal. Any lesion or ganglion cyst that appears at this region may lead to its entrapment at the Guyon's canal. Here is the superficial tendon seen just beneath the skin and the subcutaneous tissue, which is the palmaris longus. And deep to it, we can see the flexor tendons. This is the examination of the region of the carpal tunnel. Here is the median nerve with the characteristic honeycomb appearance. Beneath it is the flexor digitorum superficialis and profundus tendons. Movement of the finger can make us see the movement of the tendons. This is the flexor retinaculum. Outside is the flexor carpi radialis, and inside is the flexor pollicis longus. You can move the thumb to see its movement. And here is the radial artery. Going back towards the ulnar aspect. You can see the rest of the flexor digitorum superficialis and profundus tendon, together with the ulnar artery and nerve. Here's an LS examination of the median nerve. You notice here the uniform thickness of the nerve and normal appearance of the underlying tendon. Here we notice that there is the distant end of the radius and the scaphoid. If we put the probe TS at this region, another bone will appear in view, which is the lunate, and this allows us to examine the scapholunate ligament. This is the examination of the extensor group. Our landmark is the highest bone of the at the radius, which is the distal tubercle. Medial to it is the extensor pollicis longus, and lateral to it is the second compartment. Movement of the thumb makes us see the movement of the tendon. Moving to the second compartment, which contains the extensor carpi radialis brevis and the extensor carpi radialis longus. Then moving to the first compartment, which contains the adductor pollicis longus and extensor pollicis brevis. Moving back to our landmark, this is the third compartment, and this is the fourth compartment, which is the extensor digitorum, and the fifth compartment containing the extensor digiti minimi, which is over the radio-ulnar joint. Then moving to the ulnar aspect, we see the extensor carpi ulnaris, which is the sixth compartment. Moving on to the most common pathologies, first of all is the tenosynovitis, where we can see a fluid surrounding the tendon with increased vascularity. Sometimes we see there is increased thickness in the tendon itself. Another common type of tenosynovitis is the DR.Ahmed tenosynovitis, which affects the tendons of the first compartment above the radial styloid process, which are the abductor pollicis longus and the extensor pollicis brevis. At this characteristic site above the radial styloid process, they are named as DR.Ahmed tenosynovitis. As any other tenosynovitis, we may see fluid surrounding the tendons, increased vascularity. In chronic setting, we may see the increased synovial thickening or focal thickening of the tendons above the radial styloid process. Another mimicker of the DR.Ahmed tenosynovitis is the intersection syndrome, which occurs at the site of intersection between the tendons of the first compartment and the second compartment. So the tendons of the first compartment, which are the abductor pollicis longus and the extensor pollicis brevis, passes above the tendons of the second compartment, which are the extensor carpi radialis longus and brevis, about 4 centimeters proximal to the styloid process. At this particular site and at this point of intersection, sometimes the friction can occur between the two tendons, leading to tenosynovitis with fluid seen at this area. The differentiating point between the intersection syndrome and the DR.Ahmed tenosynovitis is that the pain is about 4 centimeters proximal to the radial styloid process, and the maximum point of tenderness is also at this point. Because in some cases the fluid surrounding the tendons may extend down to the radial styloid process, and it may be diagnosed as DR.Ahmed tenosynovitis, which is not the case. Another common pathology is the ganglion cyst. For sure, we must take its measurement and report the tendon to which it's related, as well as any nearby vascular structure. Another important pathology at this region is the carpal tunnel syndrome. Um, I'd like to do first a comparative study between the two sides. So if I can see the median nerve at this side like this, and the other one is a bigger one like this, so I'm sure dealing with a carpal tunnel syndrome. So regarding the measurement, the area of the nerves will not exceed 11 millimeters square. So we see at this side it's about 22.6, and at the other side is 10.4. So for sure this is a carpal tunnel syndrome. Here we see an LS view of the median nerve with loss of its normal uniform thickness, with a narrow point noticed just under the flexor retinaculum, which is the site of entrapment. Another method is to measure the flattening ratio, in which we take the measurement of a largest dimension and the least dimension. If the ratio between them is more than 3, so this goes with the carpal tunnel syndrome. Another sign is the palmar bowing of the flexor retinaculum. Normally, if we take a line from the pisiform to the scaphoid, and draw another line reaching the flexor retinaculum, in normal setting, it is less than 2 millimeter. If it exceeds 2 millimeter, then there is bowing of the flexor retinaculum, and this goes with the carpal tunnel syndrome. A variant of the median nerve is the bifid median nerve. Studies found out that patients with this variant are more susceptible to carpal tunnel syndrome, although there is a debate about how we can measure the area of the nerves. I still see that if there is a carpal tunnel syndrome, you can just uh, pick it up with the abnormal size of the nerve. However, one of the studies mentioned that the sum of both uh, median nerves areas should be done. This is the classic appearance of the nerve schwannoma, where we see the nerve, then the schwannoma, and the nerve continuation. This is described as the afferent and the efferent nerves. So this is the classic appearance of a nerve schwannoma. This is an example of a hypoechoic lesion seen in the subcutaneous tissue, with an appreciable space between it and the underlying tendon. This lesion will go into a differential diagnosis. It may be hemangioma, leiomyoma, a neurofibroma. Also, malignant lesions could not be ruled out as synovial sarcoma. So, in musculoskeletal imaging, some benign-looking lesions are in fact malignant. So, biopsies in most cases are preferable. So regarding the scaphoidinate ligament, as we mentioned before, putting a probe in LS at the distal end of the radius, we can see the scaphoid bone. Then moving the probe TS, another bone will appear, which is the lunate, so as we can examine the scapholunate ligament. This is the normal appearance of the scapholunate ligament, and this is an example of a torn ligament with widened scapholunate distance. Sometimes in partial thickness tear, a ganglion cyst may be seen at the site of the tear. Thank you.